Hello, I'm Dr. Johnny Lee. I'm a senior research scientist at Nestle Purina Pet Care Company. I hold a bachelor's degree in biochemistry from Xiamen University, China, a master's degree in computer science from Columbia University, and a PhD in molecular biology and genetics from the University of Texas at Austin. Prior to joining Nestle Purina, I completed a postdoctoral fellowship with Johnson & Johnson Pharmaceutical Research and Development. My research at Purina utilized translational approach to study common diseases in dogs and cats. Today, I'm happy to join with my colleagues, Dr. Dorothy Laflamme, to share our research findings in canine heart health.
Hello, I'm Dottie Laflamme. I'm a veterinary nutritionist. My training, both my master's, my PhD, my DVM, all came from the University of Georgia. And then I spent 25 years in the R&D department at Purina before I retired about 5 years ago. I've had the pleasure since then to continue on as a consultant, working with Johnny Lee and others, continuing to do some research collaboration as well as communications. And today, the two of us want to share with you some new knowledge about the dietary management of dogs with heart disease. Our talk today is a little bit about the current guidelines on canine heart disease. And then Johnny's going to talk about systems biology and how that set us on a new track for understanding heart disease and the dietary management of it. Then we're going to talk about a specific blend of nutrients that we developed and tested, and Johnny will share with you the results of some of his actual research in dogs with mitral valve disease. And we'll close by bringing it together for tying together the dietary management for dogs with both early and late stage heart disease. When we think about dogs with heart disease, we know that it is a fairly common condition, especially in older animals, affecting between 10 and 15% of canine patients. The actual prevalence is probably even higher than that, as we know that mitral valve disease accounts for about 75% of cases of heart disease and up to 90% in certain breeds. And mitral valve disease appears to be underdiagnosed. One recent study identified that 27%, almost 28% of medium-sized, medium-age older dogs had asymptomatic valve disease that was not diagnosed as heart disease. So it probably is even more common than we think it is. Now, the American College of Veterinary Internal Medicine established a consensus panel that created guidelines for diagnosis and care for dogs with various stages of heart disease, starting with stage A, which is the dog that is at risk for developing heart disease, but actually has no evidence of that disease at that point. And that progresses through stage B1 and B2, which are preclinical. The dogs are starting to have changes, but they are not showing evidence of heart failure. And then stage C and certainly stage D, which is advanced and end stage heart failure. Not only the diagnostic procedures, the medical procedures are put together by this consensus committee, but they also have made some recommendations for dietary management. According to the ACVIM guidelines, dogs in stage B2 should have mild sodium restriction, and their diet has to be monitored to provide adequate calorie and protein intake, which might require a highly palatable diet. As they progress to stage C and then on to D, the degree of sodium restriction, according to these guidelines, needs to be somewhat more, so modest sodium restriction, maintaining adequate protein and calorie intake to reduce the likelihood for cachexia. Omega-3 fatty acids are also recommended in part for the same reason, because it seems to be beneficial in addressing cachexia as well as providing an anti-inflammatory benefit. And the diet should be monitored for excesses or deficiencies. So those are the guidelines according to ACVIM. But the research that Dr. Johnny Lee is going to share with you shows that our evidence suggests that the right nutrition fed earlier can actually slow the progression from an early stage of heart disease. Johnny, would you introduce?
Let's look at the systems biology. Genetic information flows from DNA to RNA to protein. What has been added to this picture in the past decades is metabolites. Metabolite refers to small molecules, including lipids, amino acids, carbohydrates, vitamins, and cofactors. All the metabolites in a living organisms are collectively known as metabolome. The DNA provides genetic blueprints, but it is the metabolites that determines our phenotype. In this presentation, we are going to look at the transcriptomics and metabolomics data from dogs. We collaborated with Professor Lisa Freeman and Professor John Rush at Tufts University in this multi-omics systems biology study. We compare serum metabolomics and cardiac tissue transcriptomics between healthy dogs and dogs with early stage mitral valve disease. The study was published in 2015 in Omics. Serum metabolomics identified 41 known and 13 unknown metabolites that were significantly different between healthy dogs and dogs with early stage mitral valve disease. And cardiac tissue transcriptomics identified over 1,000 differentially expressed transcript or genes. The key findings, the key difference represent change in energy metabolisms, antioxidant functions, nitric oxide signaling, and extracellular matrix homeostasis. Let me just recap the multi-omic study. The study have identified several key metabolic and cellular change in canine mitral valve disease. Those changes include derangement in cardiac energy metabolisms and mitochondrial dysfunction, specifically adaptation in energy substrate, a shift from fatty acid to glucose and ketones, an alteration in oxidative phosphorylation, and energy transfer to mitochondrium. The change also include decreased protection against reactive oxygen species, RAS, which can cause cellular damage and oxidative stress, increases in inflammatory mediators. Dr. Laflamme?
As Johnny was saying, the energy demands of the heart are important and they change in the face of disease. We know that the healthy heart has a very, very high metabolic requirement. Think about it, it's pumping all the time, 24/7. So the heart actually needs almost twice as much energy per kilogram as the brain, which needs way more than even skeletal muscle at rest. Each cardiomyocyte contains thousands of mitochondria in order to meet that energy demand. And mostly they get that ATP, that energy, from fatty acids in the normal healthy heart. But as mentioned, heart disease leads to malfunction and changes in energy metabolism. There's reduced oxygen available for metabolism, and that alters the substrates that can be used. There's decreased fatty acid oxidation, and the heart then has to rely on glucose oxidation, which is less efficient. The net is reduced ATP production. So a failing heart can actually have 30 to 40% less ATP compared to a healthy heart. So based on the metabolomic data and the other and the transcriptomic data, that Dr. Lee just mentioned, we put together a blend of nutrients that we felt would be beneficial to the diseased hearts based on that preliminary research. So a cardiac protection blend of nutrients was designed to include alternate energy sources, antioxidants, anti-inflammatory nutrients, and nutrients to provide mitochondrial support. So we'll talk about each of those. First, the alternative energy source. Since the heart can't efficiently metabolize the long chain fatty acids in the disease state, it can actually metabolize medium chain fatty acids as well as ketones. And so we are looking at providing MCTs as an alternate source of energy for the heart. These shorter chain fats are readily absorbed from the GI tract, metabolized, they transfer across cell membranes, they're readily oxidized, and most important probably to the heart is that they can transfer across the inner membrane of the mitochondria without rate-limiting transporters or even without carnitine as a transporter. Medium chain fatty acids in heart failure have been shown to enhance energy production. There's a 2 to 6-fold increase in acetyl-CoA at the mitochondria. There's increased mitochondrial beta oxidation of fatty acids, decreased free radical production, so less oxidative stress compared to metabolism of long chain fatty acids. Most important, there's an increase in the ATP to ADP ratio, meaning there is more energy available. And it results also in increased contractile function in a hypertrophic cardiac disease model. In addition, MC fatty acids, medium chain fatty acids, are also a source of ketones that can also be used by the heart. In healthy hearts, medium chain fatty acids and ketones are used based on concentration. So the more there is, the more they use. And ketone oxidation is increased in heart failure, while long chain fatty acid oxidation is actually decreased. The next nutrient of interest is the omega-3 fatty acids, specifically the very long chain eicosapentaenoic acid or EPA and docosahexaenoic acid or DHA, because these are recognized as anti-inflammatory. Numerous studies in multiple species have identified benefits from the omega-3s in heart failure, with benefits in terms of reduction in the pro-inflammatory prostaglandins and thromboxanes and interleukins, reduction in the inflammatory cytokines, specifically TNF alpha and interleukin 1, also a reduction in thrombosis, reduction in blood pressure, arrhythmias, and reduced risk for cachexia. Magnesium is a key mineral that probably doesn't get enough attention. It's involved in hundreds of different metabolites throughout the body, but it's critical to normal functioning of the heart and muscle. Some of the benefits that it provides includes control of blood pressure and vasodilation, antiarrhythmic properties, decreased free radical production and therefore decreased oxidative damage, decrease in inflammatory mediators, and overall enhanced mitochondrial function. Another part of our protective blend is carnitine or its precursors, lysine and methionine. Now, we specifically use the precursors in our study. Carnitine is a peptide derivative that is produced in the body from lysine and methionine, or it can be provided intact in the diet. Carnitine is important because it serves, amongst other things, it serves to transfer as a co-transporter to transfer fatty acids across the inner mitochondrial membrane, which is necessary for those fatty acids to be metabolized to produce ATP. And since the heart is dependent on fatty acids, it's also dependent on carnitine. Now, the other thing that from the data in Johnny's study, we identified that in dogs with preclinical mitral valve disease, they actually show a decrease in serum methionine. So having a source of methionine can help address that reduction, as well as be a source for carnitine, as well as be a source for taurine, which we'll talk about here in just a moment. But the other category of nutrients for the cardiac protection blend are antioxidants. As was already mentioned, there is increased oxidative stress, in part due to altered metabolism, in part due to mitochondrial dysfunction, creating more free radicals. And so our blend included vitamin E as an antioxidant, as well as taurine, which serves as an antioxidant. Taurine also provides mitochondrial support function and helps to reduce free radical production. It also aids in cardiac contractile function and osmoregulation. And as everybody knows, it's absolutely important to have adequate taurine for a healthy heart. I'm going to now turn this back over to Johnny to talk about his research.
Cardiac protection blend, CPB, includes several key nutrients: medium chain triglyceride, fish oil, magnesium, carnitine precursors, and several amino acids. The team tested the efficacy of CPB in dogs with early stage mitral valve disease. The study was published in 2019 in BMC Veterinary Research. It was a 6-month blind, randomized, placebo-controlled study. The left diagram shows a 2x2 factorial experimental design. We had 19 dogs with early stage mitral valve disease and 17 breed, age, sex-matched healthy dog with no cardiac disease. Dogs in each health group were randomly divided into 2 subgroups. One group was fed with the control diet. The other groups was supplemented with CPB. Dogs were fed with their assigned diet for 6 months, and a board-certified veterinary cardiologist performed echocardiography at the baseline, 3 months, and 6 months. The cardiologist was blinded to diet treatment. The endpoint of the study was the 6-month change in left atrial and left ventricular dimension over the baseline. We were surprised just how quickly CPB showed effect. On the upper panel is the LAD, left atrial diameter, and the lower panel is LAAO ratio, left atrial to aortic root diameter ratio. Both echo variables measure left atrial side. A linear mixed model was applied to account for repeated measures. The linear model showed a significant diet by time interactions in both echo variables. Remarkably, the control group, which is represented by the solid line, showed increases, while the CPB group showed decreases. The change, the difference was visible, was evidenced in just 3 months. We also look at the change, percent change over baseline in the echo variables. In this graph, the dashed line represented baseline values, and the solid black line inside the boxes indicate median. The median difference between the 2 groups, control and the CPB groups, ranged from 10 to 15%, which was considered clinically relevant. Recall that we have 17 healthy dogs with no cardiac disease, and no change was found in these healthy dogs over 6 months. This suggests that our diet was safe and the observed difference was real and specific to mitral valve disease. The cardiologists also look at the mitral regurgitations using color flow Doppler echocardiography. The severity of mitral regurgitation was measured as the maximum ratio of the regurgitant jet to the left atrial area and was graded as non-trace, mild, moderate, and severe, 4 categories. In this graph, we are going to look at how many dogs had worsened, no change, or improved mitral regurgitation in both control groups and the CPB group, which is a right panel. So in the control groups, the 25% of dogs had worsened mitral regurgitation and 75% of dogs showed no change, but no dog improved. On the other hand, in the CPB groups, only 10% of dogs had worsened mitral regurgitation and 60% showed no change, but 30% of dogs showed improved mitral regurgitation. The difference between this group are statistically significant. Over the 6-month study, some dogs progressed from the stage B1 mitral valve disease to stage B2, but no dogs advanced to stage C of congestive heart failure. In this graph, the light gray box indicate the percent of B1 dogs in the group, and the black box indicate the percent of B2 dogs in the group. So the left is the control groups, right is the CPB groups. At the baseline, both groups had about equal number of B1 dogs and B2 dogs, 20% B2 dogs and 80% B1 dogs. But over the 6 months, some control dogs advanced from B1 to B2. At 6 months, it was about 6% B1, 50% of B1 and 50% of B2. But no dog had advanced in the CPB supplemented group. The difference between these two groups is also statistically significant. We also measured blood pressure. However, no difference was found. So we asked the questions, was the change in blood pressure correlated with change of left atrial diameter, LAD? So we look at both systolic blood pressure and the diastolic blood pressure. So the Spearman's rank correlation indicate a strong positive correlations between LAD change and the blood pressure change in the CPB supplemented group, but no correlation was found in the control group. There are several key takeaways from this clinical pilot study. We conducted blind, randomized, placebo-controlled diet intervention study to test the efficacy of CPB. Our study showed that CPB reduced left atrial enlargement, improved mitral regurgitation, and slowed the progression of the disease. However, no change was found in healthy dogs. The study also showed that the change in LAD was positively correlated with change in blood pressure. Serum samples was collected in dogs in the pilot study. Our hypothesis was that CPB improved energy metabolisms, oxidative stress, and inflammation. The serum and target metabolomics data, the results supported the hypothesis. This is the principal component analysis, which show the global change in metabolome. To the left is the baseline, and the right is the 6 months metabolomic data. The blue square indicate the control samples, the control dogs, and the orange square indicate the CPB dogs. At the baseline, the two groups are mostly overlapping, no difference in the metabolomic profile. However, after 6 months intervention, the two groups are completely separated, suggesting CPB has made some fundamental change in the metabolome. One can also project the samples to the x-axis in this PCA plot, which is also the first principal components. So that is the box plot on the bottoms. At the 6 months, the box plot showed that the two groups are significantly separated and the difference was statistically significant. We also look at the fold change in polyunsaturated fatty acids. The first 3 polyunsaturated fatty acids in red are omega-3 fatty acids, and the next 3 in green are the omega-6 fatty acids, and the last one in gold is the omega-9. The 3 omega-3 fatty acids had increased level compared with the control, which has little or no change. While to the contrary, omega-6 and omega-9 fatty acid had decreases compared to the control dogs. We know that omega-3 confers protective effect, while omega-6 and 9 promotes inflammations. Increased omega-6 to omega-3 fatty acid ratio has been associated with many diseases, including cardiovascular disease. Our data suggests that CPB confers protection against inflammation. CPB also contains 5% MCT. As a result, both CA and C10 medium chain fatty acids were significantly increased compared with the healthy control. As Dr. Laflamme explained, medium chain fatty acids promote fatty acid oxidation, ketolysis, and also provide fast energy, yet reducing oxidative stress. Arginine level is equal in both diets. It was about 1.5% in dry weight in both diets. However, both arginine and citrulline level are significantly increased in the CPB group compared with little or no change in the control group. Arginine is the natural substrate of an important enzyme called nitric oxide synthesis, NOS. NOS produce nitric oxide and release citrulline, and citrulline can be recycled back to arginine. Nitric oxide is an important vasodilator with many cardiovascular benefits. Nitric oxide is also an important signaling molecule. Isocarnitines are intermediates of fatty acid oxidation. Accumulation of isocarnitines in circulation signified incomplete fatty acid oxidation and has been used as diagnostic markers for disorders in mitochondria oxidations. A recent study has shown that 22 short chain and long chain isocarnitines were increased in proportion to the severity of mitral valve disease in dogs. 3 isocarnitines, C18, C6, and C17, were significantly reduced in dogs fed with the CPB compared with the control-fed dogs, suggesting improved fatty acid oxidation. Deoxycarnitine. Deoxycarnitine is the immediate precursor for carnitine biosynthesis. The heart tissue cannot synthesize carnitine, but it can synthesize deoxycarnitine. L-carnitine is synthesized in liver, in brain, and in human kidneys. The heart can use its deoxycarnitine to exchange for L-carnitine in blood streams. In dogs with mitral valve disease, perhaps the heart's ability to synthesize deoxycarnitine is compromised. So the increased circulating level of deoxycarnitine associated with CPB may indicate a pathway for the heart to increase its carnitine supplies and to promote fatty acid oxidation. To sum up, I have presented a multi-omic study which identifies several key nutrition targets in mitral valve disease: energy metabolisms, inflammations, and oxidative stress. We also conducted a blind, randomized, placebo-controlled study to test the efficacy of CPP. The study showed that CPP reduced left atrial enlargement and attenuate mitral regurgitation and slows mitral valve disease progression. The serum metabolomic study supported our hypothesis that CPB improves energy metabolisms and confers protective effect on inflammation and reactive oxygen species. And CPB also increases arginine and citrulline level, which may also potentially increase nitric oxide productions with many cardiovascular benefits. Now I will hand it to Dr. Laflamme.
So based on what we've just seen and what the ACVN has previously said, we want to ask the question, when do you actually start dietary management in heart disease for dogs? Well, according to the ACVIM guidelines, you want to start sodium restriction at stage B2. But according to what Dr. Lee has just presented, it seems to be important to actually start feeding dogs for heart health much earlier at the stage of B1, using a cardiac protection blend of nutrients, which includes an alternative source of energy in the form of medium chain triglycerides, the omega-3 fatty acids from fish oil, carnitine precursors, as well as magnesium, taurine, and antioxidants. But when you, as a veterinarian, see a dog with heart disease, you may not see it at the stage of B1. You may see it later on. So let's bring it all together and talk about the importance of nutrients in congestive heart failure or myocardial disease. So we know that based on the studies that we've shared, as well as others, we know that nutrients that are important for dogs with mitral valve disease include those energy sources, long chain fatty acids as an energy source, an alternative energy source, omega-3 fatty acids, antioxidants, magnesium, carnitine, and precursors. These nutrients all are also important in more advanced heart failure because it helps to maintain heart function as long as possible. So all of those are important in advanced heart failure. But what about others? What about potassium? What about sodium? What about calories and protein? We'll take just a few minutes to talk about those additional nutrients now. The ACVIM suggests sodium restriction is important. Why? Well, sodium is the primary osmotic agent in extracellular fluid, so it drives blood volume, which also influences blood pressure. We know that sodium and water balance are maintained carefully through renal excretion controlled by the renin angiotensin aldosterone system, or the RAS. As the heart fails, systemic blood pressure drops, and the body attempts to increase this by retaining sodium and retaining water, again, by the RAS. But the result of this is often overshooting compensation, and that results in fluid overload and edema, resulting in congestive heart failure. Medically, the treatment for fluid overload includes diuretics to include excretion of sodium, as well as ACE inhibitors to block activation of the RAS system, as well as a low sodium diet. Studies in dogs with heart disease have shown that a low sodium diet actually did reduce the size of the heart in dogs with heart failure, but very low sodium actually induced electrolyte abnormalities. Low sodium triggers the RAS system. That's the normal physiologic response as it tries to retain sodium. There's problems with that. The prolonged stimulation of the RAS system actually promotes inflammation. It increases oxidative stress. It can cause renal damage as well as vascular damage. So in dogs with heart disease, while low sodium may have decreased heart size, it also upregulated the RAS system earlier and more severely compared to dogs fed with normal or even high sodium diets. And multiple studies in humans suggest excessive restriction of sodium increases mortality in heart failure. So what is too low and what is okay? Unfortunately, there's been no controlled studies to identify optimum levels, but there are studies that have identified what is too low. In the neighborhood of 13 to 27 milligrams per 100 kcals, or 0.05 to 0.1% sodium on a dry matter basis, was associated with adverse effects in dogs with heart failure. Early activation of the RAS system, worse clinical scores, and increases in oxidative stress, electrolyte abnormalities, and decompensation and azotemia when used with diuretics or ACE inhibitors. However, in multiple studies, an amount of sodium restriction was identified that is in the neighborhood of 40 to 70 milligrams per 100 kcal, which is about 0.2 to 0.25% sodium on a dry matter basis. And at this level of sodium, there were no adverse effects in dogs when used in conjunction with diuretics or ACE inhibitors. So this seems to be a safe level. Now, putting that into perspective for diets on the market, traditionally, diets for advanced heart failure are in the neighborhood of 13 to 27 milligrams, the too low. So those low sodium cardiac diets actually can be detrimental, whereas the level of sodium in typical kidney diets and properly formulated heart diets are going to be in the neighborhood of 40 to 70 milligrams per 100 kcal, which is where you'd want to be if you want moderate sodium restriction. Calorie and protein intake in cardiac disease is particularly important if we want to stave off cachexia as long as possible. So management of these dogs requires adequate intake of protein and calories. But I want to point out that most dogs with heart disease are older dogs. And so they need protein at least as much as a healthy older dog does. And evidence suggests that the minimum requirement as established by AFCO or FEDF may not be adequate for senior dogs. Senior dogs should get at least 25% of calories from good quality protein. And so that guideline also applies to dogs with heart disease. You don't want to restrict protein in these dogs. You also want to make sure that they're eating. Dogs that do have more advanced heart failure may become anorectic either because of the disease or because of medications. And so palatability is going to be very important in these dogs. Highly palatable foods, perhaps small frequent meals. If you're feeding a wet diet, maybe warming that would help, or pouring warm water on a dry diet would help. These dogs also may have compromised blood flow to the intestines, which can compromise digestive function. And so highly digestible diets also can be of benefit. And highly digestible, higher calorie diets may also allow the nutrients to be consumed in a smaller volume of food, which could be beneficial. And then the omega-3 fatty acids, as we've already mentioned, provide an anti-inflammatory effect. And this also may be beneficial in dogs that are at risk for cachexia. So in summary, we talked about a lot of nutrients here. Moderate sodium restriction, when is that important? Energy sources, carnitine or its precursors, taurine, magnesium, antioxidants, anti-inflammatory nutrients, protein, calories, and palatability. So what this table is showing us is, when is it important? Congestive heart failure or early stage mitral valve disease, B1, B2. Sodium restriction is not important if it's for the early stage of heart failure, but may be more important as the condition progresses. But as long as it's not excessive restriction of sodium, it's perfectly okay early on. Carnitine and taurine are important for protecting the heart in mitral valve disease, and can also be very important in some dogs with myocardial disease or with congestive heart failure. So I want to look at it from the point of view of the nutrients that have been tested in the research that Dr. Lee presented to you. So all of these nutrients are included, and the blue box is showing additional conditions that might be particularly relevant to congestive heart failure. The nice thing about this is those tables, the congestive heart failure and the mitral valve disease, are not mutually exclusive, and there's absolutely no reason not to have all of those nutrients in a diet for dogs to promote healthy hearts as well as dogs with congestive heart failure. So thank you very much for your attention, and we're glad that you were able to join us.